Did you want me to introduce you by name or just say? Good evening. Hopefully everyone is enjoying the meal. This particular OVC practitioner talk is actually being sponsored by Advantix. We are quite fortunate to have them as our sponsor, and so they do have a table with some products, so I definitely encourage all of you to, at the end of the talk, to either come and chat with them or have a look at their products. And it's a good thing that they're here. I'm Dr. Chantal Pinard, your main speaker today. I've been asked to introduce myself, so most of you already know me. I am an OVC, should I tell the year? No, okay. One of my classmates is in the audience and she just said no. So back in the 90s, I graduated from OVC. I am an Ottawa girl, Franco-Ontarienne, so if there's anyone here who would like to question me in French, go right ahead. If not, English is definitely a go. And graduated here back in the 90s and went and did general practice actually. My mixed animal girl was out in full force the first year, and then that C-section at 3 o'clock in the morning, yeah, just didn't cut it. So I went equine small animal, and well, you know how equine people are. So then I went small animal. And so then I decided, you know, I really love detail. I really like to, I need to be good, and I have this perfectionism. So the bottom line is I thought, why not specialize in something? I thought about cardio, but there's too much math. So then I thought, what about the eyeballs? Beautiful, lots of colors, and doesn't smell, doesn't itch, and you can do a lot with it. You can do a lot of surgery, and I am a surgeon at heart. You can do a lot of medicine, and there's a lot of communication that you can do about eyes. So decided to do a residency, which I went to Kansas State University. Go Wildcats. If anyone is into college football, for 3 years. And then when I came back, I went to La Faculté de Médecine Vétérinaire, which is the University of Montreal in Saint-Hyacinthe for 4.5 years. And then a position opened up here, and I've been here since 2007. So that's my bio. Right now, I am the only ophthalmologist on the clinic floor, so sometimes I'm on and sometimes I'm off. For example, next month, I am doing all my didactic teaching, so I will not be on the clinic floor next month. But this morning, I was on clinics, and I've been dealing with patients. Some of you may have referred them. Mondays, I usually deal with cataracts, and so some of your patients might have been the ones that I saw this morning. So I know that you've had a full day of work, so have I, but hopefully I'll make this entertaining and educative for you. I am here for you. That is my motto in terms of if you have a question about anything that you see, or if you have a question about something even unrelated, but still ophthalmology, hopefully, I will do my best to answer. So let's start. So what I decided to do is we all see purebreds in our clinics. We see a lot of mixed breeds, but we do see a lot of purebreds. And some of you may even have some breeders that are client of yours. And so I thought this would be a good talk to have in terms of breed-associated ocular disease. So when I was looking at things, I'm like, okay, so what are the most popular breeds? And this is the list that I came up with. And so I am sure that these are bred dogs that you have seen at your clinic, or mixes of this where there's one breed that is more prevalent than another. And in one respect, you're going to say, well, how did you come up with, you know, the Golden, the Lab, the Shih Tzu, the English Bulldog, the Boston Terrier, the miniature Schnauzer, the Pug, the German Shepherd, and then Terriers as a family? Well, I actually asked our administrators here to say, hey, the stuff that gets referred to the ophthalmology service, what are the top 5 breeds? And so these are the top 5 breeds that we, at the ophthalmology service point of view, get. And then I said, well, what about the money? Are these the same breeds that I make money off of? And so you can see that all of a sudden the Shih Tzu comes up pretty quickly. And we'll talk about that. And so it's kind of interesting that we have a little bit of reversal of certain breeds. But I've also contacted some of my classmates. About a handful of classmates came back to me and said, all right, Chantal, these are the main breeds that we see. And they also gave me an idea also of the ocular diseases that they see. So that's why I kind of, even though the German Shepherd is not one that I see more commonly, but I did definitely see that the German Shepherd was coming up. And so I'm not going to talk about the Havanese, but, and some of these I may not talk about, but absolutely, if you've got questions, we'll go right ahead. So one thing that I'm going to bring you, and some of you may already know this website. I have no financial connection to this lab. However, I do have extreme confidence in this lab, and it's Optogen. So when you just put up www.optogen.com, this can definitely be one of the primary sites that you can use in order to do some testing. And if you go on the website, and then you go to tests, it will actually show over 60 breeds. So pick a breed, any breed. There's some of these that I have no idea what they look like. But most of these are going to be what they call PRCD or PRA. And PRCD means progressive rod cone degeneration, or progressive retinal atrophy, as we used to call it. And then the CEA is Collie-eye anomaly. But there's actually other tests that you can find too, in terms of, there's actually a narcolepsy test. So I did not know that narcolepsy had a genetic test for it, but the beauty of this is anyone can submit blood to these. It's not me. Family veterinarians, general practitioners can just go on the website. If you look at, and they even have, hate to say it, didn't I just see the cockapoo somewhere? There we go, cockapoo, there we go. So they even have hybrids. And if you click on that, then it tells you what the tests that they can do. And sometimes you can have a little bit more information. And then they also go through all the different types of scenarios that you can have. And when you go back to the top, I mean, you can order the test. And so as long as you follow their directions, they will basically receive the blood. Now, one thing that I'm going to say is that the information is only given to the owner. So whoever pays, and I shouldn't say that whoever pays, it's whoever is listed as the owner of the dog will get the results. The vet clinic, it does not go back to the vet clinic. So the bottom line is you then have to contact that owner, breeder, in order to get the results to put in your file. There are privacy laws that I'm told in this that are quite strict, and so the information is only given to the owner per se. However, there are definitely lots of tests that can be done, and so the more progressive breeders already know about this. And so, but if you have either a newcomer as a breeder or even someone who's been breeding for some time, might be something to discuss with them in terms of some of these tests. Not all ocular diseases, unfortunately, are genetic tested, but there's quite a few of them. And every year there's a new one that pops up. We now can do Collie-eye anomaly, which I would say 5 years ago you couldn't do. We now have lens luxation gene, and so which we couldn't even do a year ago or 2 years ago. So there's always a new test coming up every year, and the website is really good. And so if there's a company that I would trust, it would be them. So I really, really encourage you just to go on the website and basically poke around and see what they have. And like I said, the tests A lot of the information that I gave you is coming from this website. So this is one of the ways that you can actually do some help with your breeders in terms of selecting their gene pool. But there's also the OFA exams. Now, OFA, I know we all think about, or at least I always think about hips, but OFA has now taken over CERF. So the Canine Eye Registry Foundation, where I have a look, so an ACVO diplomate has a look at the animal and then can basically generate a certificate. Now, our certificates are a little bit different from the hips, for example, because the hips, after 2 years of age, it's good for the rest of their life. For me, the certificate's only good for 1 year. Why? Because there's a lot of stuff that happens over the years. And so I cannot certify a dog for life on a lot of ocular diseases. So the bottom line is that again, progressive breeders will know about this, and there's a lot of CERF clinics that they call them that are done by my colleagues in private practice at dog shows and so forth. And again, that's just an exam. Most of these are just an ocular exam. They don't do a shimmer tear test. They don't do any pressures or anything like that. All they're doing is they're looking at the eye, they're dilating the pupil, and then seeing if there's anything that looks amiss. I usually don't recommend. Some breeders really like to have their puppies surfed as soon as possible. There are some diseases that can take some time to show up, first of all. But secondly, looking at a puppy, I find that can be quite challenging, not only in the surface that you're looking at, which is quite small, but puppies either like are full bore and playing or sleeping. And so sometimes it can be quite challenging to find that window of opportunity. So definitely I don't recommend doing them before 10 weeks of age. And even then I say 16 weeks would be good. But for some breeders, they don't want to wait that long. But I do recommend that they should be done as a puppy, done when they're just before breeding, if possible. So 1 to 2 years of age. And then like the certificate is only good for a year, so during the breeding ages, that would be great. But definitely I recommend it at a later age. And why do I say that, 8 years of age? Is because there are some diseases, and we'll talk about one that's coming up in the region, the median age is 8 years of age, and it's in golden retrievers. And so if you don't certify those grandparents, because they'll be grandparents by that point, if not great-grandparents, at the age of 8, you might be missing something that, yes, takes several years to show up. But so I definitely encourage the breeders to say, no, even though the dog is not breeding anymore, bring it back to me so I can certify that the great-grandparents or the grandparents are still good, so we know that your line is not affected. So this is something to consider. It's not just during the breeding years, in my opinion, that they should have a CERF exam. And a lot of my breeders, I'll be honest with you, they just do it for their own information. But if they mail in their certificate, depending on what we find, then they will get a certificate, but now it's from the OFA. So, talked about the common breeds that I see, talked about kind of the 2 types of genetic or types of certification that we can do. Either by blood work through Optogen, but not all diseases are tested genetically. We don't have all the markers of all the genes. For example, cataracts, still not a gene that's been kind of pinpointed for a lot of breeds. There are some breeds, and you'll see this in a second, but not all breeds. Are we good? Do we have any questions so far? All right, so if we talk about Labradors and Goldens, I mean, I would assume that Labradors and Goldens are one of your bread and butter in the clinic. Am I correct in assuming that? All right, so if I'm looking through, there's a lot of things that they can get what we call presumed heritable diseases. So the first group are pretty much similar in terms of distichiasis, that's extra eyelashes, the entropion, ectropion. So basically floppy eyelids. Corneal dystrophy, so they have fat in their cornea. That usually can take 2 to 5 years before it shows up. So it may not be right there as a puppy. Limbal or iris melanoma, again, that may take, I see kind of 2 populations. I see the young kind of 2-year-old, and then I see like the 7-year-old. So there's kind of 2 populations for that. Uveal cysts, again, iris cysts, those can happen at any point in time in the life. Persistent pupillary membranes, that's what's PPM. That should be congenital because that's the iris that did not basically disintegrate as much as it should have, and there's a strand of iris, either iris to iris, iris to cornea, or iris to lens. So these are fairly self-explanatory. Then we go into a little bit more inside the eye. So the Labradors, unfortunately, are genetically predisposed to glaucoma. The Goldens are not, but they are through pigmentary uveitis, and I'll get into that in a couple of slides. Cataracts, of course, are predominant in both. Again, usually recessive. Persistent hyaloid artery, so that's when you have basically an artery that should have at the back end of the lens disintegrate and it didn't. But sometimes you can also have other types of vitreal diseases or conditions. So the primary hyperplastic vitreous, and I'll show you an example of that, or vitreal degeneration. And then we're looking at the retinal diseases. So progressive retinal atrophy, retinal dysplasia, progressive rod cone degeneration, which is again, pretty much synonym to PRA, retinal dysplasia, day blindness. This is a new one in the Labrador as far as I'm concerned. And so anything that you'll see on the further slides that you can see with the asterisks, it means that there is a genetic test through this company. So just to give you an idea of why these have been given a little asterisk. So if I were to go back and say, well, you know, what do I really want to delve into? I thought about the Labrador and I thought about cataracts. There's kind of two types that have come out. One is going to be basically the kind of typical genetic cataract, which I try to photograph here. When I'm looking at this, you're going to see this kind of triangular shape. It's a little bit out of focus because my iris is in focus. So it's actually on the posterior lens capsule. This is very characteristic of this genetic type, very stationary, slowly progressive, 1 to 3 years of age. This is enough for me to say to a service dog that it's disqualified. Because it's smack dab right in the visual axis. So for me, that would be enough to disqualify a Labrador from being a service dog. But there is another type that is more of a cortical cataract. So that can be anterior or posterior, and those ones usually progress and will end up having cataract surgery. So we talked about that persistent hyaloid artery. So where you see that little arrow there, that dot right there, if you were to see it in real eye, you would see the dot, but you would see like a little white worm. And so that persistent hyaloid artery, I'll be honest with you, is not very vision threatening. However, it is definitely an issue. And so it's something to consider. Because a lot of times it'll be linked to this persistent hyperplastic primary vitreous. So it means that the vitreous did not basically disintegrate as much as it should have. And this is what you're going to end up seeing is this plaque-like cataract. And a lot of times it'll have blood vessels or pigment in it. And again, this is congenital. If I had to pick a breed, to be quite honest with you, would not be the Labrador, would be the Doberman. But we're not going to talk about Dobermans. But this is something that if you see that, that is definitely, we think, genetic and should be considered when breeding. So degeneration or liquefaction of the vitreous, it's just that, think about it. If in the back of the lens, just in front of the retina, your vitreous wiggles and jiggles, well, that's going to put traction on your retina. And so if you put traction on your retina, it can lead to a retinal tear. And a retinal tear, and especially in the face of liquid vitreous, the vitreous goes underneath the retina and it just detaches. So a lot of times when I see a vitreous that wiggles and jiggles, then I'm a little bit concerned that this dog may be predisposed to retinal detachment. I won't necessarily do anything about it, But I will say to owners, try to have their dog not kill the toys. You know, when dogs try to kill a toy, they grab the toy, and then they just shake vigorously, and then those eyeballs go like this in the head. That's not a good thing. When you have basically a vitreous that is already liquefied. So sometimes I'll try to modify a little bit the behavior of the dog. And so the retina, the Labrador definitely has some issues. And so PRA or PRCD, it's autosomal recessive, and there is a DNA test for that. But it can take some time before I see it on fundic exam, or you can see it on fundic exam. But there are retinal dysplasia folds that can occur quite early in life. And so they look, especially in the non-tapetum, if you're looking at that top picture up there, you can see these kind of white, linear, kind of worm-like lesions. Well, they're not worms, thankfully, but they are folds. Now, sometimes they will resolve spontaneously, but sometimes they won't. And so if the adult, and again, through the DNA test, is shown to be heterozygous, our recommendation is not to breed. And you will only be able to see really these lesions, whether it's the retinal folds or the retinal dysplasia, when you dilate the pupil. So you really need to take your time when you're doing these exams, and looking through a non-dilated pupil will be very challenging for you to pick up some of these lesions, because they can be quite central, but sometimes they can be peripheral. So that picture up there, you can see an area in the center that looks a little fuzzy. Well, this is actually a retinal detachment. And it's all folds that got together and basically detached. So that area right now, if that dog were to look at this screen, it would see a black spot. Not something that whizzes by, just a static black spot. And so again, depending on how big that is, it could definitely be impairing vision, or it can even lead to blindness if it keeps on progressing. So of course, our recommendation at that point is not to breed them. And the labs have also been linked with this retinal dysplasia with skeletal defect. What do I mean by that? There is a DNA test. These are cute little labs, I'll be honest with you. Crooked feet, and a lot of times they'll have a valgus or a varus, and I never know which one is which. But they will be very short stature. They'll have kind of a longer body. And even though they're very, very cute to look at, you look inside of those eyes and you will find a lot of anomalies. Most of the time you will find some degree of retinal detachment, some degree of cataract. And again, if I had to pick, sometimes it's more the field trial line that have this. But I would definitely say, you see one of these, definitely I would not encourage breeding. And any of the progeny would be to DNA test them. And then we have this day blindness, which again, I would say it's relatively new on the market, but there is Labradors out there that, again, as puppies, you may be able to appreciate that during the day they're not functioning as well, but in low light situations they seem to really perk up, and it's because they're day blind. It's kind of like the Malamute that has hemerolopia, but this is similar. It's recessive. There is a DNA test. And again, you may only start really appreciating the behavior at 8 to 10 weeks of age. But again, this is something that we certainly don't want to be promoting. So if there's any questions whatsoever, I think the bitch and the stud should be tested to see if they're carriers. So leaving the Labrador, are there any questions? I'm just trying to focus what I thought was either very interesting or very common in the breeds to help you out when you're having these. And they're coming in for their puppy appointments. They're coming in for maybe breeding exams. I don't know if you're doing some therio. So this was kind of my thought during this presentation. We'll proceed on with the Goldens. All right, so Goldens. Love the Goldens. But we saw that the Golden can definitely have a lot of issues. And one of them, which is quite similar to the Labrador, is this posterior kind of polar cataract. So if I'm looking, this is actually an artifact of the flash, but there is this kind of triangular, kind of Y-shaped lesion back there. And again, it's kind of like the Labrador. It usually is stationary, does not affect vision, but for me, it's enough to potentially not have them be service dogs. Why? Because if the dog is walking towards light and the pupil goes small, well, it'll be right on top of the cataract. So it may lead to some visual deficits or impairment. So those dogs are important. And so it would be, for me, enough to disqualify them. But Goldens can also have a generalized cataract. And again, without surgery is the only way that they're going to regain vision. So it is something to consider. But this is really what I wanted to focus on with the Golden Retriever. So just a show of hands, who has heard about Golden Retriever pigmentary uveitis? Well, about half, I would say. So Golden Retriever pigmentary uveitis actually started maybe 10, 15 years ago. Northern states, kind of New England area. There was apparently a very prolific stud. Of course, that always starts that way. And I don't know his name. These are all rumors. But the bottom line is that this disease kind of started, and there are pockets of it, I find. And I think it's because of lines. So when I was in Montreal and I had a lot of dogs that were coming in from New York and so forth, I saw a lot of Golden Retriever pigmentary uveitis. The good news is I don't see a lot of it here. Having said that, I do have a few that have been diagnosed. So the bottom line is that I think that it is something that should be on your radar. Now, it's not associated with any other ocular systemic disease. So it's not like they had a uveitis from lepto or anything else. It's very much a primary disease. And a lot of dogs will present with these uveal cysts. So an iris cyst, which is right here, that can be a benign lesion. Golden Retrievers are allowed to have iris cysts and not have anything else. So just because you see an iris cyst does not mean that it will become a Golden Retriever pigmentary uveitis. However, it is one part of the puzzle, in my opinion. And a lot of times, if you don't ultrasound the eyes, there might be, or dilate the eyes, there might be a lot of other iris cysts that you're not seeing that are actually hiding behind the iris and will only poke through if you dilate the pupil. So one iris cyst, there might be more. And really what I would have a tendency to say, for me, the main thing, and again, I've tried to bring this up in pictures, but the bottom line is you can see faintly on this bottom picture here that there seems to be like an imprint of something here. Actually, this is a strand of iris tissue that's going from basically behind the iris, touching the anterior capsule and coming smack dab on the cornea. Here you can see a little bit of pigment migration. This could be a collapsed iris cyst that just basically ruptured on the anterior lens capsule, but it can also be that we have pigment deposition on the anterior lens capsule. And that's one of the main issues, or the main, not issues, but one of the main clinical signs of this. A lot of times they will have pigment dispersion on the anterior lens capsule. It can be a radial pattern in a lot of cases. But you will also have adhesions of either iris to lens or basically an adhesion of the peripheral iris to the cornea. And so sometimes you'll see hypopyon with this. Sometimes you'll see iris cysts that actually have blood in them. And wherever the lens has been touched, sometimes it will go white. And so the bottom line is you can also have cataracts with this that are capsular. Unfortunately, this disease, as it progresses, even though we say it's uveitis and we see clinically signs of inflammation, histopathologically, they don't really see inflammation, but they do see all these adhesions. But unfortunately, obstructive glaucoma is usually around the corner. So yes, I do start them on topical anti-inflammatory, either Voltaren or a little bit of Pred, once or twice a day if I'm really suspicious. But this is a disease that can take years in the making. I have at least 5 or 6 Goldens that I'm following right now because grandmother or aunt was diagnosed with the disease, so now they have a sibling or they have someone in the lineage and they're very concerned, and they see iris cysts and they're like, well, and I'm like, yeah, but he's 2 years of age. I can't, you know, he may not. And so this particular dog, I can't remember exactly her age, but she's definitely 8 years or more. And so right now, her pigmentary uveitis is being stabilized with some topical prednisolone acetate. Right now, we don't have any signs of glaucoma, but I am keeping a very close eye on her, having her pressures rechecked on a regular basis, at least once a month, to see if we can keep this, you know, unfortunately, devastating disease at bay for as long as we can. But I've seen when I was in Montreal, they would come to me in full-fledged glaucoma with fibrin in there and so forth. And unfortunately, the only treatment was formalin. Some of these dogs are they can just really go very quickly. Those eyes can just basically, I wouldn't say explode, but they would definitely fulminate very quickly. And so you need to be aware of this. And treat aggressively, not only with topical, but with systemic, in my opinion, and then some anti-glaucoma medications potentially also at the same time, and see if we can just keep those eyes as comfortable, pain-free, and visual for as long as we can. But it is a devastating disease, and I think it's starting to crop up. So, and Goldens, again, it takes years in the making. So, and I tell owners, you know, call back your breeder. Do not be defensive or anything. Just let them know, because if no one calls back the breeder and lets them know that this is happening, how are they supposed to, you know, advance their line and so forth? So it is something that I'm hoping that I've put on your radar today. The one colleague that I have that actually is from the States, Purdue University, Dr. Wendy Townsend. She's really the one who has taken this disease under her belt and has run with it. So if you're ever doing a literature search about pigmentary uveitis and you see Wendy Townsend, take that article and run with it. She has actually determined that yes, Goldens with iris cysts and without iris cysts, in terms of with iris cysts, Goldens with iris cysts sometimes will just be golden retrievers with iris cysts, but sometimes they'll be golden retriever that progress to pigmentary uveitis. But again, having an iris cyst does not mean that you have the disease. She's also determined, one of her recent articles was that golden retrievers, as you know, as dogs age, their intraocular pressures go down. It's just the reverse in cats. So if you were to take an intraocular pressure of a 2-year-old golden retriever versus a 12-year-old golden retriever that has completely normal eyes, the pressure in the 12-year-old will be lower than the 2-year-old. And I'm not just talking about excitement. It's just, it's been proven, and that's across any breed. So you take a 12-year-old, you know, miniature schnauzer versus a 5-year-old miniature schnauzers. Intraocular pressures decrease with age. And so some people were saying, well, these golden retrievers have low intraocular pressures. They must be having the beginnings of pigmentary uveitis, because as we know, uveitis, you usually have low pressures. But Wendy actually came out with an article saying, no, Goldens actually, even out of all the breeds, actually have lower pressures than, for example, a Labrador of a 12-year-old or a miniature schnauzer of 12 years old. So low intraocular pressures, you have to be careful about that one. Again, it is not pathognomonic for this disease. Aged golden retrievers will have lower pressures than any other breed at the same age. But cats is just the reverse. Cats, their pressures actually go up with age. So you take a 2-year-old cat versus a 12-year-old cat, the 2-year-old cat will actually have lower pressures than the 12-year-old cat. So just keep that in mind when you're checking pressures. Just, I know, we're not talking about cats, but just an FYI. Any questions? This is really a disease that I really want to put on your radar. Yeah.
Sorry, when you were saying you're progressing, you said use topical meds, oral meds. Were you talking about glaucoma?
So good question. So the question is so as I see these dogs and I'm seeing that there's more pigment, the iris actually gets darker. And so there is actually a change in the melanocytes. They actually get darker and they get more numerous. And so as I'm seeing this, if they come in with fibrin and so forth, depending on the pressure, I will either choose to use a glaucoma or not. Definitely all of them are going to be on some type of anti-inflammatory therapy. If it's mild, I'm just seeing some pigment, I'm seeing low pressures, but there's no hypopyon, there's no this, there's no that. Probably just go with a topical Voltaren, like an NSAID, 2 times a day, maybe 3 times a day, depending on what I see. But I see hypopyon, I see blood-filled cysts, something like that. And my pressures are no longer less than 10. They're now in the teens or even in the 20s. We're heading towards glaucoma. So then I'll definitely be going with my steroids at that point. Topically, plus or minus systemically. And then, but anything 20 pressure or above, well, you're heading towards glaucoma. So I would definitely add not only my topical steroids, potentially a little bit of systemic steroids, 0.5 mg per kg per day. That's all I'm talking about. You don't have to hit them with, the big block of 2 mg per kg per day. And then I'll add maybe some Azopt, 2 times a day, maybe 3 times a day. Azopt is the one that I usually go to. It's a carbonic anhydrase inhibitors. It doesn't affect pupil. So it's not like Timolol or Travatan that really puts them into meiosis. Travatan more than Timolol. And in my opinion, Timolol, it affects the heart. So if I can stay away from it, I'd rather do that. It does cause bradycardia, especially in the smaller dogs, but Goldens are slightly large, so it's not as big of a deal. But that's the one that I usually reach for first. But if my pressures are 20 and I know that they should be less than 10, I'm going to be heading, and because you don't want to be hitting glaucoma at 30. So I'm going to start hitting them with, Azopt either every 12 hours or every 8 hours, bring those pressures down. I might be able to wean them off the Azopt. I've done that. I get a dog coming in and it's the pressures are in the 20s. I've got some hypopyon. I've got, stuff going on. I've hit them with my steroids. Actually, by just reducing the inflammation, then the aqueous flows better and the glaucoma almost resolves on its own. So sometimes the anti-glaucoma medication, depending on how early you catch it, sometimes you can wean them off. Just know that you probably will. The disease progresses. So odds are you'll probably have to go back to it, but hopefully you've gained some window of opportunity. Does that make sense? Yeah.
So you're saying older Goldens have lower eye pressure
yeah.
than other dogs, so like 10 to 15
Again, it also depends on the instrument that you're using. Shiots, if I have to make a general comment, very good instrument. Yes, a little archaic. I'll get it, but only $300. Has a tendency to be a little bit higher than the Tonopen or the Tonovet if I were to compare the same dog with all 3 instruments. I was raised on the Tonopen, so for me that's kind of the golden standard. I find that the Tonovet, especially when you get outside of the normal range, I find that it kind of exaggerates. For example, we had a dog today. The pressure from the student with the Tonovet that did it quite well had a Tonovet of 3, but when I did the pressures with the Tonopen, it was 8. So it really depends on the instrument that you're using. So I can't really give you a number, but what I would have a tendency to say is whatever instrument you're using in the clinic, you'll get a feel for what you're getting. But the bottom line is that, yes, anything less than 10 should be subject. But again, an older golden retriever that has a pressure of 8, and he's just lying there, just looking at me and enjoying the view and not doing much, I'd be going, he's fine. A pressure of 8 is not necessarily uveitis in a dog that has no other clinical signs. It's just one piece of the puzzle. If he doesn't have all the other pieces, the eye's not red, the eye's not myotic, the eye doesn't have any aqueous flare, blah, blah, blah. And he's just sitting there looking at me and I've got a pressure of 8. I'm going to go, yeah, he's a golden. Does that make sense? All right. Again, Goldens can also have genetic diseases that include the retina, and so PRA, and there's actually 3 DNA tests that you can find. The classic PRCD, which again, progressive broad cone degeneration, but then there's a PRA1 and a PRA2. So again, every time I look at the Optogen site, I find that there's new tests out there, and so it's something that can sometimes be hard to keep up with. Retinal dysplasia, In this particular case, there is no DNA test, but again, the puppies can resolve. It could just be that there's certain layers of the retina that are growing faster than others, and as everything basically matures, that everything smooths out by 6 months of age. But if they're still present when they're an adult, then I would have a tendency to say not to recommend them for breeding. And again, retinal dysplasia, the same thing as the Labrador, but sometimes it cannot be apparent before 10 weeks of age. So if I have a breeder that's anxious to have these puppies surfed, I'm going to go, well, I want to wait because I could be missing something. And so I realize that that's not always convenient for them, but we want to be as good as we can get. So before going to the Shih Tzu, Goldens and Labradors, like I said, are your mainstay, and it's like anything else. If you don't look, you won't find, especially with retinal folds or retinal dysplasia. I mean, it may not be enough for that field trial dog to, you know, fail or not do well, but if they're not training properly, it could be that there is some type of visual deficit or impairment that's happening. So it is something. And like I said, everyone can Google these days. Everyone can look things up. So when you have a breeder coming in and asking questions, I want to inform you so you have all the materials in front of you when you're dealing with these with these clients. So the Shih Tzu, my money maker. Maybe not for you. It could be maybe your headache of, oh no, another Shih Tzu. Some of them are nice. Some of them are not as nice, and it's hard to muzzle a Shih Tzu, isn't it? And I'm right there, right in their face, looking directly into those big googly eyes. And so bless their little hearts with the owners, you know, that just love them so much. And they've never heard the word no, and it's good. It's all good. It's all good. Eyelids, again, I've never met a Shih Tzu that does not have distichia. So you remember what distichia is. It's that little cilia that comes out of the meibomian gland. Cocker Spaniels and Shih Tzus, as far as I'm concerned, they all come with them. Now, the good news is we don't have to chase them up, in my opinion, because Shih Tzus and Cocker Spaniels, most of them are so soft that they just wish and wash in the tear film. So just because you have distichia, in my opinion, yes, you can send them over and I can assess and see if I think that it's enough. To remove. One of the main reasons I would remove is if you have basically recurrent ulcers and these little windshield wipers are just delaying, then I'll say, okay, it's worthwhile putting them out and trying to get rid of some of these offending eyelashes. Ectopic cilia. This one definitely I will go ahead because it's the distichia, but instead of coming out of the duct of the meibomian gland, it actually comes through the palpebral margin, not through the palpebral margin, through the palpebral conjunctiva, and will end up in that puppy that just has an ulcer that doesn't want to go. Well, it's because every time it's blinking, it's got a hair that's literally not just washing, but actually perpendicular to the cornea, and that's why it's causing. So you need to cut those out, and you need an operating microscope or heavy-duty magnification, and some of them are just tricky because they're translucent. So that's where you need to use your imaginoscope sometimes to see them. Of course, all of them also have entropion, some degree of entropion. Really what I want to do is grab that nose and just pull. Why? Because being pushed in, everything just basically curls on itself. So they all have some degree of either medial trichiasis or entropion in the medial aspect. Now, the good news is they're not like pugs. Some of them will build up pigment because of the chronic irritation, but they don't do it as much as the pugs. So sometimes we can get away with it. And of course they're bug-eyed. Why? Because they have large palpebral margins. And so of course that means that if they hiccup, they can prolapse and proptose their eyeballs very easily. And they have a shallow orbit. So of course that predisposes to everything. And a ciliated caruncle means just a hairy caruncle, you know, that little mound of tissue that we have in the medial canthus. Well, they just have hair because they're hairy. And so it can wick onto the cornea and again lead to that chronic tear staining. So cornea, of course, KCS, big one. We don't have the gene for it yet, but again, it is definitely something that we consider very highly probable in this breed. Corneal dystrophy, lipid. Actually, they're not a German Shepherd, I get it, but they can get panis, and definitely the exposure keratopathy, persistent pupillary membranes, cataracts, vitreous, and again, retina. And so, this is my moneymaker in these Shih Tzus that just come in and have a beautiful melting corneal ulcer with a central desmetocele. This is actually a fusidic acid gone wrong. And so just melting away. Beautiful desmetocele with hair that is just rubbing on that desmase membrane. And so if they hiccup too much, then they might perforate. Or if they just lunge at you, then they might perforate. And these can go very quickly. They can, absolutely. And so a simple ulcer can turn dramatic. Well, they've got hair contaminating their whole face, and some of them can actually lick their eyeballs. So, I mean, the bottom line is, you know, I mean, it's not going to be sterile for long. So KCS, though, is again something that's just going to, if you don't have tear film that's containing your immunoglobulins and basically just the washing aspect of it, of course, a corneal ulcer can turn into this very quickly. And so, you know, chronic ulcers or indolent ulcers are another thing that you can see in this breed because, again, of KCS. Corneal dystrophy, if you happen to have a corneal ulcer and it heals, sometimes they'll actually throw lipid in there and then it becomes a chronic problem because the lipid in that cornea, once it's healed, is still abnormal. And so it's going to be an area that's going to be very fragile to re-ulcerate. And so it's not necessarily a good thing. Pan is similar to the German Shepherds. And this exposure keratopathy, I mean, I'm just talking about the bug-eyed dog in terms of with the big eyelids, and you see sclera 360 degrees around, and some of them won't blink properly if you do your palpebral reflex. So remember, you're touching the medial canthus, you're touching the lateral canthus, but then I always recommend with the bug-eyed dogs, take your index and follow all the way through the palpebral margin, because sometimes you'll see that you are actually touching cornea on Shih Tzus and Bostons. And so just make sure that they're not lag ophthalmic. Again, it'll just slow down whatever healing or complicate things. I mean, they are known, any brachiocephalic has lower corneal sensitivity. So they don't know that they've got a hair in their eyeball. And so the bottom line is that it just leads to corneal ulcers. And referral to me in conjunctival grafts. And so this is something that, I mean, if you want, I can certainly give you my kind of recipe for corneal ulcers. I mean, we don't really have B&P anymore on the market. You can get it compounded. So my first line is tobramycin, 4 times a day. Means first thing in the morning, when they get home, supper time, last thing before going to bed. Because you got to figure out what their schedule is, the owners, because if you don't, then that's why they're not going to follow your directions. So I kind of asked them, so what can you do? No, it's not perfect, but it's better than nothing. If that is not responding, and I will recheck them every 3 days, because like I said, a simple ulcer can go really, really bad very quickly. So if we're not getting anywhere, then we may want to switch to a fluoroquinolone. So your ofloxacin, potentially your ciprofloxacin, and again, a minimum of 4 times a day. Of course, they have to be wearing that famous e-collar, which, you know, all owners love. But a lot of these guys are face rubbers. I mean, they just love going onto the shag carpet or going from one end of the couch to the other end of the couch with their eyes open. And so the bottom line is we have to protect those eyeballs. So the e-collar is adamant. If there's any meiosis, a little bit of atropine twice a day. Once the pupil is dilated, it's paralyzed. It's anesthetized. You don't need to follow up with more atropine. Atropine also decreases tear production. I'd be checking the tear production in these dogs, because if the tear production is 15 and they've got something nasty like that, well, we've got a tear production problem, because we should be 25. These things are painful. Now you have to be careful. Can you rupture a desmetocele by doing a Schirmer tear test? The answer is yes, because I've done it. So just pick and choose the case that you want to do a shimmer tear test on, maybe not on a Desmetaseal, but these are all things. I mean, it's just, we need to figure out what the owner can do, what is, you know, the best for the dog. If it is melting, definitely serum. And I don't use serum from that dog. I use serum from a golden retriever or a Labrador that's nice and healthy, that I can hit a vein easily. And not get a hemolyzed sample. And again, that would be every 2 hours. I'd be doing the serum, because the serum is there to basically bind the collagenase and the protease that's leading to the melting. So doing it 4 times a day is okay, but you might as well do it every 2 hours, because that is just continuously melting. And again, if they want to do everything, sometimes one of the only options is to go to surgery. So it's better to refer too soon than before the eye ruptures. Knowing fully well that not every owner can be referred. When you're looking at a conjunctival graft, definitely my technician can give you some estimates, but off the top of my head, I would say in hours, you're probably looking at 25. So for some owners, that's doable, and for some owners, that's not. But if you aggressively treat it, if you aggressively monitor it, and you know where it's going, then you can avoid the 35 to 4 out of hours fee. And so that is also something to consider. So Shih Tzus, one thing, yes, they've got the big bug-eyed appearance, but actually they also have some fundic lesions that you may not want to skip over. One of the things, and it's very hard to photograph, is to get that vitreal degeneration. And so again, if you're looking back there, and if they happen to have some floaters, such as asteroid hylosis, and you see this wiggling, jiggling of floaters back there, that means that they have some vitreal degeneration or liquefaction. So vitreous should be viscous. It should be like egg whites. It should be jello. If it's swaying back and forth, that's not good. And like I've said before, it can predispose to retinal detachments. And of course, Shih Tzus love to kill their toys because they all think that they're big dogs. And so the bottom line is that sometimes we do have to do some modifying of behavior. And if there's a little bit of a cloud of something in the anterior chamber, usually by the pupillary aperture, you'll think, oh, I'm seeing a little kind of cobweb, or I'm thinking maybe it's a little bit of fibrin. That's probably vitreous that's coming from the back end of the eyeball, coming around the lens, through zonules, because it's liquefied, and coming into the anterior chamber. That's another indication that your vitreous is probably not as solid as it should be. And if that happens, then you can get these tears. This example here is a giant retinal tear where actually the top of the retina has actually folded over. And so if you imagine, in the palm of my hand is where the optic nerve is, so the dorsal retina has done this. And so if I'm going here, this is basically, retina has no pigmentation. The tapetum has pigmentation, but retina is like a veil, and so it's kind of grayish. So this is kind of the leading edge of it that's folded over, and there's actually a fold right here, but here is the optic nerve actually. And so spontaneous retinal tears I have seen quite often, and again, these are not painful. A lot of times it'll happen in the first eye, but a one-eyed dog runs as fast as a two-eyed dog, so they won't even know that they're blind in one eye until it happens in the other eye, and then you figure out that there's actually bilateral retinal detachments. In the Shih Tzu, another retinal thing is progressive retinal atrophy versus retinal degeneration. Just like in the Labrador, in the Golden Retriever, PRA, progressive retinal atrophy, is usually a bilateral disease. But the Shih Tzus have this thing called retinal degeneration, which again can be somewhat confusing. But the bottom line is degeneration can be unilateral, which kind of goes against the genetic thing, but I don't have all the answers, but this is what they're reporting. And again, degeneration may affect more the males than the females. And you're going to go, well, how do I know degeneration versus PRA? Well, the bottom line is odds are what the owners are going to report for both cases is that the dog is not doing as well at night as it is during the day. And more likely, for example, they don't want to use the stairs unless you turn the lights on. And so if there's some visual impairment, visual deficits, I can do an electroretinogram and again, try to figure out which one it is. Unfortunately, there's really no treatments for this. I mean, you can put them on supplements, but there's really no indication at this point in time how effective they are. And then optic hypoplasia versus micropupilla. I mean, potato, potato, or is that tomato, tomato? I don't know. But the bottom line is those can really look the same. How do you know that it's hypoplastic versus micro? To be honest, sometimes it can be really hard to know which one. So if you're looking at an optic nerve and it looks like a little nubbin of something, then if it's functional, then I would have a tendency to say that it's more likely to be micropupilla, but it could still be just mild hypoplasia. But it is something in the Shih Tzu. And a lot of times I've seen, not necessarily Shih Tzus, but dogs that come in, and they have a little bit of anisocoria and realize that, yes, one optic nerve is actually not working when I'm doing my PLRs. And so, but the owners didn't even realize that they had a one-eyed dog. Are we good about the Shih Tzus? The money-making Shih Tzus? They're so popular, and I can see their attraction. I really, really do. I mean, they're cute, they're fuzzy, they're fluffy. Most of them are nice. But they can have their diseases. English Bulldogs. Now, those are money makers for a lot of different reasons, but we're just going to talk about the eyes. So the big thing that I see in these guys are definitely things that are related to eyelids. So either it's upper and lower eyelids with distichia, ectopic cilia, entropion, ectropion, but also the prolapse gland of the third eyelid. And so they definitely have a predominance of this. However, it might be interesting to note that KCS is also not just because they have a prolapse gland of the third eyelid. There are some bulldogs out there that have never had any issues with their third eyelid and still develop KCS. Cataracts and retinal folds are definitely something also that can be seen. So distichiasis, again, if you use a little bit your imaginoscope, you can see these are translucent, but you can see little hairs coming out, and they're here, 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 here. Then I lose focus here, but here, 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 here. Now, as long as they're curling away from the cornea, we may not need to do anything. But bulldogs are not renowned to be soft and cuddly. Well, maybe cuddly, but not soft. And so these can be little thorns. And so if they're not pointing in the right direction, can definitely be leading to clinical disease such as corneal ulcers. So again, in a case like this where I have several, and I mean multiple, going after each and one of them, yes, it's an option. But the problem is when I go in and attack that follicle, I'm also destroying the meibomian gland. And you're going to go, who cares? I'm going to go, yes, but you need to care about mebum. That is a word. Mebum is basically like sebum, but it's from the meibomian gland. That's why it's called mebum, but it's your top layer of your tear film. Right? Remember your ocular pathology and so if you don't have good secretion of that lipid layer, then your aqueous tear film will evaporate more and will be unstable. And so the bottom line is it'll give like a KCS disease, but it's not a production, it's more of a quality thing. So sometimes in these cases, what I end up doing is a modified entropion surgery, is I just evert the eyelids just a little bit more. So I'm not attacking the meibomian glands, but I'm just everting a little bit more so those little cilia are no longer touching the cornea. So that is an option instead of going and attacking every single follicle. But ectopic cilia definitely, again, it's more of a young dog disease. But ectropion and entropion, I mean, look at that face. I mean, who wouldn't love that face, right? So they've got very much laxity of their lower eyelid. It's almost a breed standard. But when you're that lax, what will happen is certain parts will start to roll in. So again, I would love to take that nose and pull it out. And so all that skin would stretch out, but I can't. So again, the medial canthus, a lot of these dogs, it's not that the nasal fold is touching the cornea. It's the fact that it's putting pressure on the medial canthus to roll in. And sometimes you'll also have lateral entropion because you have such a central deep ectropion that, again, the lateral margins will actually roll in. So sometimes I do need to do what I call functional cosmetic surgery in order to relieve any irritation. I mean, some of these dogs are just so lax. I mean, they can swallow small children in there. So the bottom line is I tell the owners, look, I mean, we can give him the bulldog look, or I can do a little bit of nip tuck and basically, you know, shorten that up and then hopefully deal with any irritation that's happening. Because no one likes to have, you know, looking at a bulldog with red eyes. And so it is something to consider. But one of the main things that I get referred is that famous prolapse of the gland of the third eyelid. And so one study said that, you know, 100% of theirs happened prior to 1 year of age. And I would agree. Across the board, though, with any species, with any breed, I would say the prolapse gland of the third eyelid is usually a puppy thing. I've seen it as early as basically, I would say 8 weeks of age would probably be the earliest I've had. And it's just, there's a laxity somewhere that's happening. A lot of times it'll start in one eye, but happen 3 months later in the other eye. And when that gland is exposed, it's not happy. And when it's not happy, it gets quite inflamed. And the problem is the longer you wait and the longer it gets inflamed and just builds on itself, the harder it is to put back into place. So some people will say, well, let's wait till we neuter him. Well, I get that. But the problem is first of all, the cartilage may bend irreversibly at that point. And secondly, if the gland just keeps on puffing and puffing and puffing, it's probably getting damaged. And even if you do replace it, it may not function as well. And so I usually say, let's not wait on these too much. And it's best to, the minute it pops out, to surgically replace it. These are tough to do. I'll be honest with you, if I'm going to have a recurrence, it's probably going to be on a bulldog or a mastiff. And so I am so happy when you guys refer these to me because my numbers get a little affected. But the bottom line is think twice about doing a bulldog in private practice. They can be quite challenging to do. And KCS, again, it is something that, no, it's not a small dog that you can tuck underneath your elbow, but they are definitely one of the hot breeds for KCS. And talking about cuteness, talk about the Boston Terrier with just one eye. So this is Suka. Suka is a wonderful little Boston Terrier. He's one of my favorite patients. But Suka had quite a few diseases that are on this list. And so, although his charm makes up for a lot of it, he ended up having cataracts. There is actually a genetic test for this, one of the few breeds that you can do that on. Following cataract surgery, he got glaucoma. And so, unfortunately, we lost the eye. And were the two linked together? Could have been, but they also, when we submitted his eye for histopathology, we knew that he had goniodysogenesis. So unfortunately, there's writing on the wall for the second eye on this. They are a hot breed for basically glaucoma. But if I had to pick something that I would like to put your attention to in Boston Terriers is actually corneal dystrophy. And corneal dystrophy, again, can happen in much older dogs. I mean, the mean age that we cite here is 9.5 years. And so it's not something that's going to happen right off the bat. And sometimes it'll happen in an asymmetrical appearance. And when I'm talking about corneal dystrophy, I'm not talking about the lipids in the cornea. What I'm talking about is endothelial decompensation. The corneal endothelium should be keeping the aqueous out of the cornea. So your corneas right now are dehydrated, and basically the collagen fibers are so well aligned, that's why it's transparent. The light can actually filter all the way through. But you let water in, you let aqueous in because your endothelium is no longer a good barrier. Those collagen fibers start to spread, and it's no longer the proper spacing for light photons to go through. So that's why you see it as blue. So this is what corneal edema is. It's just, you've just got fluid, and the collagen spacing has increased, and the light scatters, and you see it that way. But it's coming from the endothelium, not from the epithelium. And again, older dogs, starts unilateral, but most of the time will progress to bilateral. Again, if I had to pick an area where they start, when you're looking up top in that Boston, you can see that the temporal, temporal quadrant is usually the first one that gets affected. Don't ask me why, but sometimes it is. And then the later stages, though, is what happens is that, so you have all this water molecules that are in between the collagen fibers. But what happens is if the collagen fibers start to distort and that water molecules start to really form a vesicle or a bulla, what will happen is that bulla will actually migrate through and will end up ulcerating, just like this last picture here, will end up ulcerating on the surface. And so these dogs are very much prone to corneal ulcerations. They'll be very superficial most of the time. They will be hard to heal because you've got so much edema there. Sometimes they can get infected, which then becomes tremendously challenging to treat. But Muro 128, your hypertonic saline, either as a solution or as an ointment, but you need to use it 4 times a day. Doing it twice a day is a waste of time. Because what you're doing is you're fighting a constant stream of aqueous into the cornea. So you need to keep on pulling that water out. And so if you only do it twice a day, I don't know that you're going to get your money's worth. If you do it 4 times a day, you might be able to at least stabilize what you're seeing. Unfortunately, the disease will progress, and even Muro 128 may not be enough. And so at that point, there are different techniques that we can do. The gold standard was the thermokeratoplasty, where you actually scar down the cornea so those water molecules can't join anymore and make a bulla. Problem is there's a lot of scarring. The newer thoughts are actually doing some modified conjunctival grafts, is what I've seen in the latest meetings I've been at, is by putting a thin strip of conjunctiva. Yes, you do decrease visual acuity, I won't get away from that, but by having those blood vessels, it keeps the edema down because it actually has somewhere to go. So those are things to think about. The sooner we do it, the better. And so these little guys, unfortunately, can become quite painful. And when it gets very severe, I mean, they're visually impaired. And so they'll be running into things, which of course with bug-eyed dogs, running into things is not a good thing because then trauma increases. Corneal ulcers are just around the corner. So something to think about with your aged Boston Terriers. I love Boston Terriers, don't get me wrong, but this is something that is out there. Of course, glaucoma is always something very devastating. And the glaucoma that I have seen is actually linked more to cataracts, but after cataract surgery, but it can be on its own. And yes, we know that the angle is not well formed, and we have the technique to do gonioscopy. What does that mean? It means that I put a special contact lens on the eye and I can look at the iridocorneal angle. The iridocorneal angle is basically the drain of the eye, right? So if it's not well formed, like in Bassets, like in Cocker Spaniels, and a whole lot of other breeds, then we would say, oh, well, we should be doing gonioscopy on all of these. The problem is that it's not very predictive. You can have a Boston Terrier with a beautiful looking angle that still goes to crap, just like you can have an angle that doesn't look very good, but they still maintain vision. And so there's a lot of controversy of how predictive that is. And so there are some ophthalmologists out there when they're doing surf exams that will include gonioscopy as potentially a type of predictive value. But in my opinion, there's a lot of controversy. It's not always 1 + 1 = 2. But the Bostons can get 2 types of cataracts. And we talked about how there is a DNA test available. So this mutation here has been actually discovered. And so, but it's also been discovered in the French Bulldog and the Staffordshire Bull Terrier. And the Australian Shepherd have actually a different one because it's a type 2, not a type 1. But this is really one of the only kind of cataract genetic tests that is out there, and not all breeds. And so the type 1 basically is a rapid progression, usually less than 6 months of age. But there's also a type 2, which is not necessarily related to this mutation, that again, 4 or 5 years of age. So again, I mean, it can take several years for these things to pop up. That's why our surf exams are only good for 1 year, because there's no way of predicting some of these things. So we've talked about Boston Terriers, talked about Bulldogs. How are we doing? All right, we're going to move on. Miniature Schnauzers. How many people have miniature Schnauzers? Oh, no one owns a miniature Schnauzer. Okay. They're very popular. I mean, I find in medicine, if they don't see a miniature Schnauzer per day, it's quite unusual. And miniature Schnauzers are great dogs. Don't get me wrong. But unfortunately, just like a lot of breeds, have their own issues. And again, you're going to see some patterns in terms of distichiasis. Again, most of the time, I don't chase those up. Corneal dystrophy, KCS, again, something to consider if you're starting to get some corneal ulcers. They may have that. Persistent pupillary membranes, again, that's something that they're born with. Cataracts can occur at any point in time. The vitreous degenerating. There is a genetic test for progressive retinal atrophy, and we do have some retinal diseases. So coming back to the cataracts, there are again 2 types. And so there is the miniature Schnauzers that come up with very, very small eyes. So kind of like the Shelties and the Collies that are just born with microphthalmia. When you have very, very small eyes, a lot of times there's your embryology didn't work well in that particular organ. And so you will have more than one anomaly. And one of them that is going to be the easiest to find is actually the cataract. And that's actually autosomal recessive in the miniature Schnauzer. But you, and these cataracts are usually kind of in the center, but a little bit also posterior. And again, very early on in life, and they can progress to involve the entire lens. But you also have this late onset cataract that's also been reported, and we think, again, heritable. And so the bottom line is when I'm looking at my 2 pictures here, I mean, this is more of an example of the early onset, basically nuclear. But here we've got the Y sutures, and this is going to progress into an immature cataract. And so it's going to potentially progress to blindness and involve the entire lens. And so these are things that can be seen. But I'll be honest with you, the Schnauzers that I see are all diabetic. And I don't know if diabetes has been linked genetically, and I'll throw it back to the audience. Do you know if genetics and Schnauzers have been linked? But we've all seen our diabetic Schnauzers. So if I can just kind of take an aside moment again with diabetes and Schnauzers. If there's one species or breed, I should say, where I've seen the diabetes blind a dog within a week, but lead also to fulminant uveitis to the point that it's glaucoma the 2nd week, is the miniature Schnauzer. So if you've got a Schnauzer that you've just diagnosed with diabetes, I think it should go home with a bottle of Voltaren. or Nevanac or ketoprofen, but I'm not a fan of ketorolac, ketoprofen, so I go with Voltaren. But the bottom line is that schnauzers with diabetes, I mean, you just need one sugar spike that basically will set up a hyperglycemic event in the eye that will basically overwhelm the fructose pathway. It goes into sorbitol. The sorbitol can't diffuse out, so water rushes in. The lens fibers, instead of being nice, well aligned, now all of a sudden are all mishmash because water went in. They start leaking protein. Eye is not happy. Protein is there, sticking everything. Fibrin is being exuded. And the next thing I know is I've got a 360-degree posterior synechia from the iris sticking onto the lens capsule. And we've got a recipe for glaucoma and an eyeball that goes into formalin, because it's very hard to do cataract surgery on those. So these can happen. Any diabetic dog, not the cats, not humans, not the horses, although I've never really seen a live diabetic horse, but the bottom line is dogs, you get diabetes, there's a high likelihood that they will get cataracts. So you need to, anytime you're doing that blood glucose curve, you should be spending the time to look at those eyes, dilate the pupil and have a look. If there's nothing going on, you can hold off on the Voltaren, but you start having a suspicion, then start them on Voltaren. Voltaren is nice, it's an NSAID. It won't interfere. I'm not gonna bugger up your insulin curve with going with NSAIDs. And if it's really fulminant, then add it on with either carprofen or meloxicam. Hit them with topical as well as systemic NSAID. And again, I mean, I'll just run to my steroids if I'm really, up a creek. So the bottom line is you go with some topical systemic NSAIDs, you can still do your blood sugar curve. You can still get all of that going. Once they're a little bit more regulated, then you can get them to me, and then we can potentially think about cataract surgery. But you want to be ahead, not behind a curve of lens-induced uveitis. So the next time you see that diabetic schnauzer coming in, just start thinking, oh, Dr. Kennard said something about Voltaren. Maybe I should have a look at the eyes and see. And if I think that I see a cataract, that's going to start leaking protein, and they can go very, very quickly. Those are the eyes that I have lost, is miniature schnauzers. So I don't want to scare you, but I want you to be well prepared, because some owners, cataract surgery is not for everyone, but there are some owners, and if you miss that window of opportunity because the uveitis just got so out of control that you now have glaucoma and blah, 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 they're no longer really a good candidate for cataract surgery. So you got to stay on top of it. Question? Yep.
Do all of them get cataracts? Or
So the microphthalmia, the question is do all of them have cataracts? I would say the great majority do have cataracts if they have microphthalmia. Now, they may not have fulminant cataracts of, oh dear God, they're also blind, but odds are the programming was not optimal. That's why they have microphthalmia. If they don't have cataracts, odds are they'll probably have some degree of retinal dysplasia. So when they have small eyes, smaller than you would anticipate, and you're thinking they have congenital microphthalmia, take the time to dilate that pupil to make sure that you're not missing anything, whether in the lens or in the fundus, because there's a high likelihood. Is it 100%? No, but it's very, very high. So I would have a tendency to say that there's more chances of seeing a cataract or retinal dysplasia in a microphthalmic than in a normal eye for a miniature schnauzer. Does that answer? Okay. All good questions. So retinal atrophy, there is a DNA test that you can do, again, because it can take some years. So if you have an active breeder that wants to be selecting puppies and so forth for their next breeding line, then that is something that may help them out. But you can also have this kind of low amplitude electroretinogram, which is kind of like a PRA. And so, but it really takes several years before it really rears its ugly head. And so, but it's early detected, not by a DNA test, but by an electroretinogram. And again, an electroretinogram, you'll find that here at OVC or most of my colleagues in private practice. The pug, the cute little pug. So again, we're dealing with the bug-eyed dog with the pushed-in nose. I mean, again, it would take away from some of their sweetness, but the best thing I want to do is grab a hold of that nose and just pull it out. Because I would have a tendency to say, without fail, the pugs, I have seen a few, but very few that don't have that medial entropion right here. It's not the nasal fold that's touching the cornea. It's just, there's just too much skin here, and it's just rolling in. And basically, they get this exposure pigmentary keratitis. That is different from the pigmentary keratopathy, and I'll get into that in a second. But again, they can get a lot of several things that we saw in other breeds: persistent pupillary membranes, cataracts, vitreal degeneration, and some retinal diseases. So pigmentation of the cornea, there's kind of two varieties of this, two types. The most common, and I would say 9.9 times out of 10, the one that you're going to see is pigmentary keratitis. Now, if you all know Dr. Wilcock and have attended his ocular path rounds, he will say that this is a misnomer. Tomato, tomato. The bottom line is that chronic irritation from that entropion, from cilia that are touching the cornea, will lead to this metaplasia. There may not be inflammation per se, but there's definitely some changes that are happening. And so the cornea will start laying down pigment. Why? Because it's trying to toughen itself up. And so by doing so, however, you do impair some vision. So early on, you're looking at that medial canthus and you see that kind of wedge-shaped pigment spot. Well, if you're not careful, I'm not saying that you'll automatically end up like this poor patient, but that pigment can certainly cross over into the entire cornea and render them blind. So you want to make sure that they've got a good tear production. You want to make sure that if they do have an entropion, see if they're willing to get referred in order for that to be repaired, to minimize more pigment deposition by minimizing that corneal irritation. If they don't want to do that, then it's called tear gel, or Tears Natural PM, or some type of ocular lubricant, optics care, just to basically lubricate and decrease that corneal irritation. The pigmentary keratopathy, it's basically associated with congenital uveal pathologies such as persistent pupillary membranes. Not necessarily as common as the first one. What you guys are seeing is a pigmentary keratitis. Yes, you can put them on steroids. What that will do is will reduce the metaplasia and will reduce the irritation. The problem though is we also know that pugs are prone to KCS, and being bug-eyed, they're prone to corneal ulcers. So you have to be very careful with any type of NSAID or steroids that you put in there to pay the price for the pigmentation. German Shepherds. German Shepherd owners in the crowd? A few. I am a fan of big dogs. They are big dogs. And for me, I do see German Shepherds, and I only really see them, although I did have a white German Shepherd this morning, and that white German Shepherd had corneal dystrophy. It had lipid deposits. However, the one, again, that I would be putting your money on is either the second one, the plasmoma, or atypical pannus, and certainly pannus, the chronic superficial keratitis. They are also another big one, if I had to choose, also a limbal melanoma. So you have basically a melanoma that starts at the limbus and will grow basically either way into the cornea as well as into the sclera. And it does have other issues. And again, retinal dysplasia, optic nerve hypoplasia, or micropupilla. Again, if you don't dilate and you have a good look at that optic nerve, you might be missing them. But coming back to this pannus, this chronic superficial keratitis, even though we have yet to determine the gene, in my opinion, it's definitely presumed heritable. So what do I mean by atypical plasmoma? So it's all lymphocytes and plasmacytes that are going in there. and basically attacking tissues. If you look at this third eyelid right here, it's the only case that I had on pictures, but you can see, and I know it's 2D, so use it a little bit your imaginoscope, but these are all little nodules, okay? They are raised, and you should not have depigmentation of your third eyelid like that. And in very severe cases, it will actually go pink, so you will no longer have brown there. And so that is basically just of the third eyelid, but you scrape that and it'll be full of plasma cells and lymphocytes. But we've seen the typical pannus. So where it starts in that ventral temporal and it looks like granulation tissue, it will, with chronicity, will have pigmentation that will come. Sometimes will also be linked with some lipid deposits, that really white crystalline deposit. And then doing my research looking at this, they were talking about haplotypes in terms of there's been an association with pannus in the German Shepherd. And so if you have this haplotype, this MHC class 2 risk haplotype, then they are much more at risk to develop pannus. But I also know that UV radiation can also increase the severity of pannus. So there's a couple of things there to keep in mind. And so this haplotype may need to be investigated in order to see if they have it. I've encountered some German Shepherd breeders that are very cognizant of this problem in the breed, and I have met some German Shepherd breeders that are completely in denial, where they have told me point blank that they've never seen this and they've never had it in their line. And I say, you know, great if you've never had it in your line, but it is definitely a very common disease and something that we need to be guarding against, because if we don't do anything, if we don't put them on topical anti-inflammatory therapy, this will progress. I have seen German Shepherds from rescue operations where they come in blind because they are just covered. It's kind of like the pug that just covers with pigment that goes from medial to lateral. The German Shepherd is just the opposite. It goes from lateral to medial. But if you don't keep that in check, and unfortunately I can't cure it, I can manage it, but if it's not constantly being monitored and treated, it can lead to blindness. So that's the last thing that we want. And this picture, oh, yeah. So good question. So if I go back one, in terms of, does the atypical pannus or plasmoma, which is really the third eyelid, does it get treated the same as the chronic superficial or the regular pannus? And the answer is yes. Sometimes you can get away with less. In terms of, what do I mean by that? Sometimes, for example, if I have this case coming into me, I'm going to hit it with topical prednisolone acetate or Maxidex, probably 3-4 times a day with a little bit of Optimmune on the side. Hopefully, in a month, a lot of this will have decreased, and so I can start decreasing my frequency of steroids, not of Optimmune or cyclosporin. And hopefully the cyclosporin is there to hopefully reduce the amount of steroids that I need. There are some dogs that I can put into quote unquote remission with just cyclosporin. With my plasmoma, odds are I probably don't have to, especially this early of a case, I probably don't have to hit it that hard because it's not blinding also. It's just a third eyelid. But a lot of these dogs, they will be irritated. They will tear more. And sometimes I'll see that the medial canthus is all eroded from all the lack of tears that are there, or not the lack, the surplus of tears that are there. So I will potentially go with my topical steroids maybe twice a day with cyclosporin and hopefully be able to maintain them more easily on cyclosporin. And sometimes I'll even increase my percentage of cyclosporin to either 1% or 2%, but then you go compounded because remember Optimmune is only 0.2%. So that's one of the cases where I'll go to compounding cyclosporin. Some of them will also respond to tacrolimus. And so they're usually a little bit easier to treat or at least to keep managed versus the chronic superficial keratitis. But I'll be honest with you, it's when you just see that little lip of raised kind of granulation tissue, that's when to get them and to put them into remission. When they start invading the cornea, they're way harder to treat. And for me, pannus in a German Shepherd, I've never seen it earlier than 2 years of age, and usually by 5 years they'll have it. So 2 to 5 is usually my corneal dystrophy, chronic superficial keratitis. A lot of those is a 2 to 5 kind of year range that I see them coming in. Oops. So cataracts, you can definitely have cataracts. In one respect, there's, again, 2 types that they say in the literature. One that is congenital, and it's basically very uncommon to rare. But the other one is more cortical, where basically it can progress. I'll be honest with you, and you have to use, and we may have to lower the lights in here, but if you use your imaginoscope and you're looking, whoops, wrong one. You're looking at this picture here. If you use, and again, it's a 2D picture, so if you use your imaginoscope, yes, there's a flash artifact that's right there. This is actually my arm, so don't pay attention to that. But right here, you can almost think that it's kind of a greasy thumbprint. Actually, in real life, what it looks like is steel wool, and just very fibrillar right in the nucleus. I'll be honest, that's the type that I have seen in German Shepherds. They're usually not, they're usually older German Shepherds that I see this in. So it's not what is described there. I'm just letting you know what I'm seeing. Most of them do not progress to blindness, and so I don't usually do anything. Most of them don't leak any protein, or at least anything that is measurable enough to say, wow, there's clinical uveitis there. But again, more easily seen with a dilated pupil, and you're looking through into the nucleus and you're like, yeah, there's nuclear sclerosis there, but there's something kind of shiny right in the middle that looks like steel wool is the best analogy. That would be the type of cataracts that I've seen in German Shepherds in this area. So terriers, rat terriers, fox terriers, soft coat and Wheaton terriers, Tibetan terriers. Help me out. What other terriers are there? Cairn terriers, yes. Anything terrier. Lens luxation. But the good news is we now have a DNA test. And not only for the terrier breeds, but for the American Eskimo dog, the Australian cattle dog, the Chinese crested, the Chinese food dog, that I had to look that one up, the Lancaster Heeler, and the Volpino Italiano, which I am sure you all have breeders of that in your clinic, which, if I'm not mistaken, pretty much look like the American Eskimo dog. So white fluffy thing with lots of teeth. Great personalities. So there has been a gene that has been identified. So your Jack Russell Terrier that comes in and has basically, it looks like a contact lens in the anterior chamber. Well, you should never see the equator of the lens. If you see the equator of the lens, it is either abnormal in terms of shape and size, or it's abnormally located. And so this is actually in front of the lens, in front of the iris. And of course, as the lens comes forward, it also pulls some vitreous with it. And so that's where your glaucoma most of the time comes in. It's not necessarily physically because the lens is in the anterior chamber. Well, that certainly doesn't help for aqueous to flow around, but it's also the vitreous that gets pulled into the pupillary aperture and also causes a pupillary block. And so lens luxations are definitely an issue in terriers per se. And so the bottom line is, if you've got breeders of terriers, again, I would highly recommend, because lens luxation surgery can be costly and can definitely have its complications. So the bottom line is, yes, I can do surgery and remove this, or I can do what we call a couching procedure, where I physically will use a Q-tip through the cornea, try to push the lens into the vitreal chamber, and then squeeze the iris shut. So I've caused a permanent posterior luxation, but then at least hopefully the glaucoma won't ensue on that. However, I've also set up that dog for permanent uveitis because that lens is going to turn into a cataract because it's bathed by vitreous now, no longer aqueous, so it won't get the proper nutrition. So it's not a full bore solution to this, but the bottom line is there are things that we can do. But if we can hopefully prevent the breeding of these dogs, I think that's even better. And so again, this is relatively new on the market. And so it is something for you to also consider. So we've come to the end of our presentation. I've hit the breeds that I think are the most popular or the ones that generate the most money. But I throw it back out to you. Pick a breed, any breed. Burmese Mountain Dogs. Well, let's see what my little book says. If I can spell it. There we go. So I know that's not big, but let me see if I can make it a little bit bigger. Oops, no, that's not what I wanted to do. No. God, it is late. Maybe 75. There we go. So this is actually my cheat sheet. When I do eye certifications, there is a book published by the ACVO that helps me to determine what are the big conditions, ocular presumed genetic conditions that I should be looking at. And so every breed will have kind of a cheat sheet right in the top. And so if I'm looking at Bernese Mountain Dogs and I'm looking at entropion, ectropion, distichiasis, when it says breeder option, it means that this will certify. If I see a Burmese Mountain Dog and I'm doing an OFA, I will say, oh, he's got distichiasis. But the reason why it's breeder option is because that little cilia will not blind. Well, shouldn't blind. Versus the cataract can blind. So that's why when I'm looking at this, cataract will say no. And so they can send in their paperwork, but they won't get a SURF number. I still send in my sheet. So it still gets recorded. So it's not like, the breeder, it doesn't count. But the thing is if it comes up with one of these, then it's breeder option. But a cataract, retinal atrophy, or systemic histiocytosis, of course, is no, because they're all blinding disease. And then in my little book, then of course, there's a little bit of a blurb on all of them, blah, blah, blah. But then, and references. But then I also have this where I can look and see, oh, look, there actually has been some iris cysts, even though it wasn't mentioned in the list, but I can see, well, 0.2%, 0.4%, 0.3%, and 0.6%. Now, I have to take these numbers with a little bit of grain of salt because these are all dogs that have been brought, that are breeding odds are, and have been brought to an ophthalmologist. So it's not necessarily representative of the general population. However, it's a starting point. So like I said, if someone brings me a Burmese Mountain Dog and it has a cataract, they won't send in their paperwork because they won't get a SURF number, but I'll send in mine. The breeder information will not be public, so it's not, but at least now I can register, and then when I'm looking at the lens, I will be one more case that will be all types of cataracts that are being seen. And again, it even says how many have been normal. And so during the different years that have been looked at. So pick a breed, any breed. Standard poodles. Yeah, they are. Oh, standard poodles. Well, we can look here too. Because if you're looking, I'm pretty sure they have the golden doodle thing. Where is that? Yeah, golden doodle. Look at that. Golden doodle. I have the generic progressive retinal atrophy that you can test for. And this is right optogen. This is blood here. This is not the OFA that I'm doing there. So you can send in blood from a golden doodle and get the 2 types of progressive retinal atrophy, even ichthyosis, whatever that is, because it's not an eye thing. So I don't know what that is. It's a skin thing. So golden, Optogen is progressive enough. They are starting to even go with, you know, hybrids. So let's have a look though here for, I think it's under poodle that I have it under, because I think they lump all the poodles together. So they have toy, miniature, and standard poodle. So these are all the things. So definitely hate to mention glaucoma, big nasty one, not good. Cataract, again, not good. Again, DNA test is available for retinal atrophy. Well, we know that because we just saw it there. Optic nerve hypoplasia. And then up there, actually they have, yeah, microphthalmia, not good. Because they think that, again, could be blinding. Anytime it could be blinding, that's when they put no as breeding advice. If it's something like an entropion, well, first of all, that's a fairly easy surgery to do, but in itself should not be blinding. So, since we don't really have anyone else suggesting a breed, why don't we, it's already, the time has flown. The time has passed, and I know that the roads are not very good, so why don't we call it a night? Thank you very much. So one thing is have you, we're done? So 2 things that I wanted to do. Well, the first thing is that I wanted to introduce to you my technician. Suzanne is my right hand. Some of you may have talked to her